Yeah, good day, everyone. This is the Concept Academy USMLE Step 2 webinar um, for us. So, just as we always say, we are not in any way projecting ourselves as the specialist of the field. We are only trying to help. So, if at all you expect us to say it in a particular way, and we are not saying it that way, please forgive us. We are not the experts. All right, so today what I'm going to do with us is just to continue briefly from where we stopped. But before I continue, I want to make a point. With respect to the present, I think I talked about it last time. So you have your step 2 to write, you have your step 3. I think this is just the best time for you to quickly tidy up your table, write your exam, most especially the step 2. So it's not supposed to slow you down. I think this one should even give you the speed, so that immediately when they open up again, most especially for those that are in the affected countries, you will be able to like you don't need to now say you are just starting at that time. I think that would be a very grave mistake. So just continue your preparation, be focused. So that's just my advice for you. All right, the last time we met, I don't think we did anything on tachyarrhythmia. For those that attended, did we do anything on tachyarrhythmia? Did we do anything on tachyarrhythmia? Oh, wow, nobody here attended our last class. Oh, that's why. Okay, I will just start from tachyarrhythmia. All right, you see, the most important point you want to first of all put at the back of your mind is the heart rate. So which means when they give you the question, the heart rate will be given. You will see the heart rate being given greater than 100, and that will first of all give you an impression that something is going on with respect to this heart rate. All right, so our main focus is just very simple. You want to diagnose, then from diagnosis you want to know how to treat. So that's the focus. So once we mention anyone, your focus is, okay, what's the diagnosis? What do I see here that is making me to go for this? Then what is the treatment? The first one is what we call the sinus tachycardia. So sinus tachycardia, so it's a normal physiologic response, as we all know. So heart rate is first of all greater than 100, and it's usually due to something like fear, pain, exercise. You might be wondering, how will this be tested? You just imagine someone that recently had surgery, and that patient started having pain and the likes. So by the heart rate, so maybe they are just focusing on what do you want to do with respect to the heart rate that is very high. Just control the pain. So control the pain, and the heart rate should be better. It can also be secondary to hyperthyroidism. So with respect to this hyperthyroidism, now there will be a clincher in the question that will bring you towards it. They will give you the TSH being very low, and with respect to volume contraction, you will see the blood pressure will be given, it will be low. So these are the things that when you see them in question, you just be like, okay, this is what is causing it, so that you won't be overthinking. All right, so we'll still come back to some of these hyperthyroidism and the likes. If I have the opportunity of unraveling the mystery behind endo step 2 for you, you have a lot to learn, so like to understand from the endocrine system perspective of step 2. Very simple concept, and you really appreciate them. So the next one is atrial flutter. So atrial flutter. So everybody here knows about atrial flutter in the name of this sawtooth ECG pattern for the P wave. You can see the P wave sawtooth, sawtooth, sawtooth. And if you look at the RR interval, it's quite regular. All right. So that's the main thing. Once you see it, you will know that this is a, so this is basically what is going to give it out in the exam, that this is atrial flutter. Now, the question is, what will they now be asking you in the exam? So number one is just the diagnosis. What's the diagnosis? You see the ECG, you just pick it atrial flutter. For all you care, that might just be all they ask you. So the second important question, that's our number one question. Number two question is, what is the cause? So you talk about reentrant circuit. That's where the problem is coming from. Where this is now the next thing they usually has this one in step 1, really not step 2. This one, so careful tricuspid isthmus. So never forget it for those that are preparing for step 3. Careful from inferior vena cava, tricuspid from tricuspid annulus. All right, so it's just within this region that you see that reentrant circuit passing through. So can you see the question? The first question is the diagnosis itself, which you just look at the ECG and pick it. The next thing is, what is the cause? Reentrant circuit. Where? Careful tricuspid isthmus. These are the questions you are expecting. They are like these have been the question, and they will always be the same question. All right, the next question is now the management. So is the management. Now, before you pick your answer for the management question, you need to check for something in that question. You check for what we call the stability. Is this patient stable? Is this patient not stable? So the patient that is stable, for you to know whether the patient is stable or not, you check for the blood pressure. Is this patient dizzy? And the like. So if the blood pressure is very, very low, this patient is not stable. Do you get it? If the patient has been complaining of very bad dizziness and the likes, the patient is not stable. So that is what you check for. And that will determine, is whatsoever you now see, that will now determine what your answer will be. So if the question says that the patient is there is hypotension and the likes, it shows the patient is not stable. Now say, what is the best next step? So your answer will be synchronized cardioversion. So let it be registered at the back of your mind now that I, Lagbaja or Mon Lagbaja, I so person. When I get into the exam and they ask me question and I check, and it's all about this arrhythmia saga, and I check for the stability of the patient. Most especially if the patient has a pulse. And I check for the stability of the patient, and the patient is not stable. What I will pick as my answer is synchronized cardioversion. See the way I put it carefully. So I don't have to be looking for what is the treatment for this, what is the treatment for that. I will just say that sorry. So I would just say that I see a question now. In that question, I check. Do you even have a pulse? No matter what you are having. Oh, you have a pulse. Then I now check again. Are you stable? Oh, this patient is not stable. Synchronized cardioversion. Can you see the way I put it carefully? Do you have a pulse? And like put it at the back of your mind like that. At least it's going to help you in a majority of questions. All right, synchronized cardioversion. So, but if you check the patient is stable, you check for all those stuffs. The treatment basically is actually this beta blocker or calcium channel blocker. Do you get it? But initially, we usually say you should attempt Fager maneuver. It doesn't mean Fager maneuver will treat it. It's not going to treat anything. So, but it's going to make you to diagnose whatsoever that is ongoing there. At least it will become more apparent. So that's that. So first of all, attempt Fager maneuver. Then from there, you now go to the treatment itself, beta blocker or calcium channel blocker. And this calcium channel blocker, they are the non-dihydropyridine calcium channel blocker. Okay, let me just show you one or two questions just for you to have an idea of how this could play out. So really nothing much. A 60-year-old man with history of hypertension and coronary artery disease present with palpitation, shortness of breath, dizziness. On physical examination, his blood pressure is 130/80 and his heart rate is 120 beats per minute. So first of all, I can see blood pressure is okay. The Are we together? Hello, can you all hear? Am I audible? Okay, all right.
Yes,
So
yes.
just to be sure. Okay, so you check this. You can first of all see the blood pressure. Now check the heart rate. Now say heart rate here is more than 100. Something is going on. The NATI ECG shows a sawtooth pattern of atrial activity at this rate. Can you see with ventricular rate? So because they will give you the rate for the atria, they can also give you the rate for the ventricles, ventricular contraction. So this is actually where the atrial rate is coming from. Can you see all these P waves that you can see here? Why this R wave will give you an idea of the ventricular contraction. So they now ask you that which of the following is the most appropriate initial management for this patient. So what you are going to do here is that you will now quickly come and check, is this patient stable? Is this patient not stable? So if you don't check, you will pick all answers will look like potential answers to you. So you need to be very careful. You now check, are you stable? Are you not stable? So the question they are giving you is say, okay, this patient history of this with palpitation, shortness of breath, and dizziness. Just say this patient is dizzy. You are like, this patient is not stable. You check at the vital signs. Check the blood pressure. The blood pressure is not down. Do you get me? The blood pressure is not down. The patient is not having hypotension. Because basically, how we normally check for stability in the hospital, you just say, is that patient stable? You say, the patient is stable. Now say, okay, what is the vital signs? Or anytime you want to justify whether a patient is stable or not, you mention the vital sign together with the SpO2. You just quickly give the doctor and be like, this is it, blah, blah, blah. And it's okay. The patient is stable now. All right, check for the pulse is high, the heart rate is high, the blood pressure is okay. So which means that there's still good perfusion going on there, even though the heart rate is very, very high. So they ask you that what's the most appropriate initial management for this patient. So your best initial management will now be something like what? Beta blocker or non-dihydropyridine calcium channel blocker. So you just check through all the options and pick that. Now you can see synchronized cardioversion is there. So if you are not very careful, you could have gone for that if you don't understand the how to justify stability. I don't know. Is it that some people are trying to ask questions or what? I don't know. Okay. All right. So if you don't know how to, you need to understand how to justify stability. So let us assume that they just mentioned that this patient is dizzy, but they do not give you the vital signs. Then you take the patient as unstable because you don't even know what is going on with the BP. You might think the patient is okay, but the patient is just not okay. Do you get it? So if all these vital signs were not mentioned, then we are going to assume the patient is not stable. All right, so that's how you will be looking at all this, and that's what is really going to help. So look at this next question. 45-year-old woman with significant medical history present with palpitation, lightheadedness. ECG is showing atrial flutter 2:1. So you see 2 P waves before 1 QRS will appear. The patient is stable and hemodynamically normal. Now say which of the following is the most appropriate next step. So the most appropriate next step is first of all to bring it out and let the diagnosis be very, very apparent with finger maneuver if the patient is stable. So you go check for that. But if you want to treat it itself, you give beta blocker or non-dihydropyridine calcium channel blocker. So your answer here is going to be attempt finger maneuver. If you look here, you can also see perform synchronized cardioversion. So if you are not very careful because you have seen it in the test, you don't understand how to justify it. Some people will quickly go for it, and that would be wrong. All right, that would be wrong. Okay, that makes sense. So that's how you'll be looking at atrial flutter in the exam. Nothing, the question will not go beyond that. It's just going to be around those stuff. It won't go beyond that. So all you will need is now to justify. And I've mentioned what they test in step 1. I've also mentioned what they test in step 2. Now you come down to what we call atrioventricular nodal reentry tachycardia. I know you've heard about it before. Let me try to unravel the mystery behind this guy for you. Just pay attention to the clincher that will give it out for you. All right. You see, if you draw the heart like this, these are the atria. Then you draw the ventricles like this. So we have what we call supraventricular tachycardia. Do you get me? Supraventricular tachycardia. So which means everything is occurring above the ventricles. Can you see? It's occurring above the ventricles. So now there is what we call atrioventricular nodal reentry tachycardia. Atrioventricular nodal. So there is AV node here, and you have what we call a reentry problem. There is a way this AV node is anatomically wired to conduct two pathways. One of them is slow pathway, another one is fast pathway. Do you get me? One of them is slow pathway, another one is fast pathway. So that's the first thing. All right. So when there is a problem with respect to this pathway, so the patient is going to develop what we call the atrioventricular nodal. This is actually where I'm going to, not to be discussing the pathway, nodal reentry tachycardia. So it's like when the wave is coming, it's going to go back again and now cause the depolarization at the upper part. So there will be a tachycardia. Do you get it? It will come, go back again, come, go back with occasional escape into the ventricle. All right, so it will go back again. So you can see the way the thing is just like returning back. So you can see it will come, the wave is coming, then go back again, then it's going to escape here to the ventricle to cause the depolarization of the ventricle. But all those ones being said, you don't really need to bother yourself about that. And I'm very, very sincere with you. You don't need to bother yourself. Just know that with respect to atrioventricular nodal reentry, the problem is at the AV node. That's number 1. Number 2 is that, how will I identify this in the exam? How will I identify this in the exam? So you see this ECG they are giving here, that is actually how the ECG will be given. This is how it's not going to change. So when you see it, you will know that this is looking more like atrioventricular nodal reentry tachycardia. So you can see the QRS complex is not wide, it's still narrow. You can see narrow QRS complex, narrow QRS complex, narrow QRS complex. And we used to say something that the P wave is not obvious, that you can't see P wave there. Even though sometimes we are going to hear us say the P wave is a retrograde P wave. Do you get it? It's a retrograde P wave, which actually makes sense. You can see the way the thing is returning back. So you think about it, the wave escape here, then is turning back. So you can see this ventricular contraction, and after that the wave will come back to the atria and is now going to cause this atrial contraction. And around the time the atria will be contracting, sorry, so around the time the atria will be contracting, so you realize that the ventricles might even be coming into their relaxation mode. So sometimes you just even see the ventricles are also contracting around the same time. So anything can happen. So this P wave can also be buried within the ventricular repolarization mode. Do you get me? Ventricular repolarization. So P wave You might not see it, or it comes after the ventricular contraction. You can see the QRS complex, QRS complex, QRS complex, QRS complex. So you don't really make reference to the P wave. So let us summarize this. We say that when you get into the exam, this same ECG will be given to you. That's number one. Number two is that the ECG may show no P wave before the QRS complex. So no P wave before the QRS complex. So if you check here, you can see P wave. So don't go and misinterpret this wave here as the P wave. Do you get it? So may show no P wave, no P wave, no P wave, no P wave before the QRS, because you are supposed to have P wave before the QRS complex. All right. The next thing is that, wait, there is no P wave before the QRS complex. We say yes. Is this not atrial fibrillation? Be very careful. We only mention ECG, number one. There is no P wave. You are like, okay, there is no P wave before the QRS complex. You get into the exam, they are not even really making reference to the P wave. You are not like, oh, this is not atrial fibrillation. Be very careful. You need to check for something else, and that is the pulse. That will help you to differentiate this from atrial fibrillation. The pulse here will be regular, whereas in atrial fibrillation is going to be irregular. Can you see the way you are differentiating them? So when you get into the exam, you look beyond P wave. You need to check the pulse. You look beyond P wave. You need to check the pulse. So if someone is coming and is like, okay, ECG, there is no, they can't see the P wave, or the P wave is buried or something, or they're having retrograde, or anyhow, they might not even be that detailed. And you're like, oh, am I dealing with atrial fibrillation? Am I dealing with AVNRT? Ask about the pulse. Check the pulse. If it's irregular, you are most likely dealing with AVNRT. You are most likely dealing with atrial fibrillation. If it is regular, you are most likely dealing with AVNRT. So that's how you, first of all, separate them. Chest pain, usually they don't have chest pain. They can also have chest pain. So really not the myth of that you should be focusing on whether chest pain is there or is not there, because the same way the chest pain here, you can also have it in atrial fibrillation, even though chest pain is even in a way a bit more common in AVNRT in a way compared to atrial fibrillation. So just ignore the chest pain aspect of it. Focus on the P wave ECG, the ECG, and the regularity of the pulse. Okay, now what else? You've diagnosed it, they just give you the wave, ECG, you just say, oh, this AVNRT. What else are they likely going to ask you? It's actually going to be the treatment. So how are you going to treat? So the same way you have been treating other people, you bring it, you check for the stability of the patient. Is this patient stable? Is this patient not stable? So if you check and you realize that the patient is not stable, just go for your synchronized cardioversion. That's the answer. Just the blood pressure is down, the patient is feeling like this, the patient is having this, the patient is having that. Then your answer will be synchronized cardioversion. Just the same way you look at the atrial flutter. If the patient is stable, you check the vital signs, everything is looking okay, your best next step will now be Fega maneuver. That's your answer. So what you want to note, take into the exam from here, is the orderliness. Step 2 is all about order. I will do this first. After doing it, I will go to this. After doing this, I will now go to this. That's what it's not about. Do you know it? They know you know a lot of things that are not in order. If I ask you now that, how will you treat stable AVNRT, and someone is saying Fega maneuver, another person might say ablation, another one might say adenosine. If you look at those answers, they are correct, but they are scattered around. That's not what step 2 is all about. Step 2 is all about, do you know the first thing you do? After that, and that one does not help, do you know the next thing to do after. So it's all about order. So when you are reading, pay attention to order. So if this question says the patient is stable, what you would first of all do is finger maneuver. So what are these finger maneuver? It can be carotid sinus massage. You know where your carotid is and just be massaging it. That's going to stimulate the vagus nerve. It's going to stimulate the vagus nerve and actually help in controlling the tachycardia. So but under which condition must you never, even if someone is whispering to you that go for it, you must never go for this finger maneuver. Or carotid sinus massage, to be very precise, if there is a prior history of myocardial infarction, TIA, transient ischemic attack, or stroke, you must never go for carotid sinus massage. The reason is that when I have the opportunity of looking at Neuro Step 2 with you, I will show you like a very wonderful understanding of stroke. So there is a vascular component of some stroke from the carotid vessel. You just see that particular thrombus can just be dislodged. Do you get me? If it's dislodged, it's going to travel down to the brain and block the distal vessel. In the course of you massaging, you can also dislodge another one. That is why you must never do carotid sinus massage. In someone that had TIA before, stroke before, or MI before, don't go and do it. So when you are reading the question, you know that your finger maneuver is the first thing you will do. So your duty will now be, is there any trap they've laid down in this question why I must never do this finger maneuver? So even though you know the answer is finger maneuver, you now quickly flip through the question and you are now saying any history of stroke, and that's the understanding they want you to display. So you will not pick something like carotid sinus massage as your answer, which is a form of finger maneuver. You won't pick that one again. You can just go straight to the next step. Okay, let us assume that you've done the finger maneuver and the patient is still having the problem. They now say, what's the best next step? The question will have said that finger maneuver is done and the thing is still there. They now say, what's the best next step? The best next step will now be adenosine. Never forget this drug, adenosine. Adenosine. They will ask it, they will test it. So adenosine. If the question says that adenosine has been given, the patient is still having it, and that's what's the best next step, you now go for catheter ablation. Catheter ablation. All right, catheter ablation. So now there are two pathways that I've been mentioning, slow pathway and fast pathway, in this heavy node. Between the two of them, I will just mention which one do you want to ablate. The one you want to ablate is actually the slow pathway. Never forget that. The reason is that if you go and ablate the fast pathway, so the heart rate is going to drop so significantly where that the patient might not even be able to survive it. You don't want to do that. So you go for the slow pathway, and because that's even the origin, that's even the main one that is really causing the tachycardia. So the one we ablate is the slow one. You leave the fast one alone. So in the exam, when you see them contemplating, is it the slow, is it the fast, is it the slow, is it the fast, you go for the fast. You go for the slow one. You leave the fast alone. Don't touch the fast, so that the heart rate will still be maintained. All right. So please never forget that at all. All right. So how can we prevent? Now this patient has been sorted out. The patient is now okay and shaking everybody. Doctor, hugging the doctor that thank you for saving my life. I thought I would die, but you saved me. Now say, okay, what else can you do to prevent future episode? You now teach the patient, if it's mild, patient can do finger maneuver. Just say, okay, anytime you are feeling like this, the tachycardia, just rub your carotid sinus area. Can you see? Just massage it. So you just realize that the thing will resolve. Okay, thank you, doctor. But if it's severe, and in the severity, you need to emphasize what can make it to be very, very severe. Do you get it? Maybe the patient is already becoming unstable and the likes. You now say that we might actually need to do catheter ablation, so you need to come to the hospital. Apart from carotid sinus massage, is there any other form of Fega maneuver? And that is ice immersion. I don't know if at all you remember House, this movie called House, that at a point someone was having SVT and the man just, I don't know if I remember very clearly, he took the ice and just poured it on the patient, and the patient was, everything just disappeared. So in case you are shouting when you are the ice block in the hospital, you just, and the nurse is like, what do you need the ice block for? You just take all those ice again, just pour it on the patient. In the hospital, there should be a place where you can get all these ice block. They have ice block machine, so you just go pack as many as possible, pour it on the face of the patient. The patient will, the thing will just resolve. It can resolve. If it doesn't resolve, then you go to this adenosine. So like a patient with this carotid sign and that is having prior history of MI, TIA, stroke, instead of you doing carotid massage, you now go and do something like ice immersion. Do you get it? So that would help. All right. So that's about it. Let me show you one or two questions just for you to have an idea of how this could be. This now, we have up to like 16 questions we treated. Do you get it? But the thing is that's why all our videos are long, and people are always saying your videos are long, because I don't even know what they want from us. You want us to show you, at the same time solve a lot of questions. At the same time, you don't even really want us to like you don't want us to solve question. You want us to solve question. You don't want us to solve question. I don't know what people really want. So I'm confused as you are. So I will just solve this one question. Basically, a 28-year-old woman comes to the mind department due to palpitation and feeling of her heart raising. You just say, my heart is raising for the past 3 hours. Over the past year, she has had similar episodes that result with deep breathing, which is also a form of what? Fega maneuver. So, but this episode has lasted longer. The patient has no chronic medical condition and takes no medications. She does not use tobacco, alcohol, caffeine, or illicit drug. Blood pressure is looking not bad. Pulse high. The neck is supple. Thyroid is normal. There is no lymphadenopathy. Lungs clear. ECG is shown. Let me show you the ECG. Let me show you. Which of the following is the most likely cause of this patient symptoms? So let me show you the ECG. So can you see the way the ECG is? And that's actually how it will be given. So it won't change. The picture does not change in the exam. So you can actually just see it and just shout on top of your voice, FANRT, and they will still say they agree with you. Even if you don't know, you just see someone like something like this, just say FANRT, FANRT, FANRT. If they don't call it FANRT, they can call it supraventricular tachycardia, because supraventricular tachycardia is a canopy name, it's a big name that all these things fit under. All right, so this is FANRT. You can see. All right. So they are asking you that which of the following is the most likely cause. So you already have an idea that it's actually a pathway problem. Do you get me? You have 2 distinct pathways, slow and fast, and because of that, you are having like a reentrant circuit, and that's that. I will still show you that pathway briefly later in this page. All right, I want you to look at this question. Let's look at this one, have an idea of what this could be. 46-year-old woman is brought to the mining department by her wife 1 hour after the onset of chest palpitation. Just a quick. Symptoms began suddenly, which characterize FANRT: sudden beginning, sudden onset, sudden termination. Sudden onset, sudden termination. Atrial fibrillation does not start like that. So those ones are gradual onset, gradual termination. All right. And I'll say her symptoms began suddenly while she was having some beers. with friends and have persisted since then. She has not had shortness of breath, chest pain, dizziness, loss of consciousness. She has experienced this palpitation before, but they typically resolve spontaneously within a few minutes. She has no history of serious illness and takes no medication. Temperature is looking okay. Pulse is very high. Respiratory rate good. Blood pressure is fine. So if you look at this patient is looking stable. No chest pain, no dizziness, no loss of consciousness. Vital signs looking okay except for the high pulse rate. ECG is shown, even though I don't have it, but you already have an idea of how it will be. Repeated forceful exhalation against closed glottis. Do you get it? So that is more or less like Valsalva maneuver. So while supine fails to relieve this. So you can see what kind of, if that is Valsalva maneuver, so which maneuver has the patient done now? Which maneuver has the patient done now? Am I alone or we are together?
Vega.
Yeah, that is what? Figure, right? So immediately you now check, they say the patient has done this but fails. So immediately that one fails. What do you think should be the next thing the patient should do? Or you should do for the patient?
Adenosine.
Adenosine.
Adenosine. So your answer should be what? A. Do you get it? So that's how you look at it. Let's check. That's very correct. That's how you are going to be doing it in the exam. So if I were you, what I will sit down to do is to master this, ask my friend in discussion group, how are we even supposed to be treating? Because the question they ask Dr. A might be about cardiovascular. This person might now come and be like, yeah, I wrote exam yesterday. They asked me something about AFNRT, and the answer I chose was cardiovascular. You also get inside, you go and choose cardiovascular. As the patient is getting 200, you will also be getting 200. But you will need to come and be like, under which condition will I pick that cardiovascular? All you need is that, okay, if I thought someone will give you an idea of what was tested, okay, you ask me a question on AFNRT, that's fine. You now quickly come and revise how you do the treatment and be like, okay, I will quickly check for this. If this is there, I will pick this. If this is not there, I will pick this. So that's that. What about another form of supraventricular tachycardia? And that is what we call the AVRT. So if you look at this one, this is AVRT. Can you see? This is AVRT. It is not AVNRT. So N is not there. So it shows that this is not occurring at the level of the node. There is another pathway that is causing this one. There is another bundle that is usually causing this one. Usually we call it bundle of Kent. So this is where this one occurs. Let me show you in this diagram. Usually you see it around this area, bundle of Kent. It's just more or less like a small bundle that is just channeling, that can channel, what do we call it? Wave of depolarization from the atria to the ventricle. Do you get it? So that's that. So a very good example under the AVRT is the one of Wolff-Parkinson-White syndrome. So USMLE love Wolff-Parkinson-White syndrome a lot. They really love it a lot. So that's what we are really going to focus on. So that's what we are going to really focus on now. So what is happening in that Wolff-Parkinson-White? That bundle of Kent is there. In step 1, that is what they will test. They can test bundle of Kent when they give you maybe ECG on Wolff-Parkinson-White. But in step 2, I will show you what they are going to be asking. All right. So Wolff-Parkinson, I put an arrow on it because it's a very high yield concept. All right. So when they give you this ECG like this, you need to quickly check for these guys. Number 1, delta wave. You see, sometimes you need the eyes of God to see the delta wave in the exam, because you might really look away, and whereas that delta wave is there. So that delta wave is occurring as a result of what we call pre-excitation. Let me show you what it means, what we mean by pre-excitation. If this bundle of Kent is shunting wave of depolarization from the atria to the ventricles. So the ventricles will have been pre-excited. Do you get me? Before the wave will come, before the real wave of depolarization will come from the AV node. So you can see these two parts now. One is from bundle of Kent, the other one is from AV node. So this one that is coming from this bundle of Kent is what will now cause this delta wave. You can see the way it is bending. When you draw your delta, this is how we write our delta, like this. This is delta. So this is the same way the wave will look like. Can you see? Delta. That's why they call it delta wave. All right. So because of this delta wave, you now see that the PR interval now becomes shortened. Can you see? The PR interval that should be up to here from here is now shortened from here to this point where this delta wave is starting. So it's shortened. So when you read the question and they say the PR interval is shortened, the delta wave is there, you already start suspecting. Then the QRS complex, because of this delta wave, the QRS complex is now looking widened. Can you see? It's now looking widened. So you now start suspecting that, okay, this is looking more like Wolff-Parkinson-White syndrome, WPW syndrome. So that's that. So that's just identification for you to say this is it. So what the USMLE will ask you is now this one. You want to check, is this patient having symptoms? Is this patient not having symptoms? Because you may actually be seeing a patient that will have this ECG, but the patient is not symptomatic. Maybe the patient is just doing pre-employment screening. So the patient is not symptomatic, no symptoms. So what you do is to observe. We know you are not the angel of doom. Don't give bad news. Just reassure the patient and observe the patient. So if the patient is symptomatic, maybe the patient is having palpitation, is having dyspnea, is dizzy, what you do is to quickly give these drugs. So these are the two drugs they are most likely going to also test in the exam, apart from the definitive treatment. So procainamide or amiodarone. So how am I going to remember these two drugs? So how many of you know Wolff? You've seen a Wolff before? A Wolff. Wolff. So some people are like, Festus, which one be Wolff now? Just say whatever you want to say. Have you ever seen where a Wolff will be saying, like, I don't know what you call the sound. So you can imagine a Wolff. Just, if you see a Wolff, you will run naturally. Amiodarone. There is nobody that will see a Wolff that will not run. So amiodarone. Then when you see the way the Wolff used to sound, you can look at that as the Wolff is proclaiming his magnanimity. You can look at it like that, procainamide. So procainamide, then amiodarone. So the definitive treatment is that bundle of Kent. You just go there and ablate it, and the patient will be fine. Now, what is the trap here? You must never give this patient any drug that will reduce conduction at the AV node. Because if you give the patient beta blocker or non-dihydropyridine calcium channel blocker, the conduction at the AV node will now reduce. There will now be more conduction through the bundle of Kent, and that will be more dangerous for the patient. All right, so you don't give the patient beta blocker, you don't give the patient non-dihydropyridine calcium channel blocker, you don't give the patient all those stuffs. And that is about Wolff-Parkinson-White. So USMLE Step 2 love Wolff-Parkinson-White syndrome very well. So you can sit down and think about the kind of question you are most likely going to be given. Let me show you one question here or something. So just for you to have an idea, 22-year-old woman with no significant medical history present with to the main department with palpitation, dizziness, heart rate. On ECG, there is a short PR interval, wide QR complex. The reading is regular. The patient has a delta wave. What is the most likely diagnosis? So you'll be looking for something like Wolff-Parkinson-White. If that is not there, you'll be looking for atrioventricular reentrant tachycardia. This one has nothing like N in its name. All right. Then you come down to atrial tachycardia. Atrial tachycardia. All right. With respect to atrial tachycardia, so what you have here basically is just like the atria just contracting at a very, very high rate. Wait. What can make the atria to be contracting at a very high rate? Okay, maybe you have all manner of what do we call it? Like ectopic sites for contraction at the atria. Do you get me? So if you have, like, let me say this is the atria, this is the atria, this is the ventricle. So you now have this site, so that are generating the wave of depolarization. So the next thing you see is that the atria will be contracting at a very, very high rate. So that will give birth to atrial tachycardia. Do you see? Very easy and straightforward. So really nothing much about this one. Nothing much about it. There is a particular form of it that you must now take into the exam, and that is the multifocal atrial tachycardia. Wait. And like, why multifocal? Which one is multifocal atrial tachycardia? This is very high yield because of the way they will coin it in the exam. You see, they are going to peg it. They call it multifocal because there are so many regions that are generating all those that are serving as the ectopic pacemaker. That's multifocal. That's why it's multifocal. That's number one. Number two, it usually occur in collaboration with, under the premise of cardiopulmonary conditions. So it might just be someone with COPD. It might be someone with one condition that is related to cardiopulmonary systems. Do you get it? So when you see that, you will be like, they will give you this ECG in the exam. And there is something you will see in the ECG that will give it out. You will see what we call at least 3 different P wave morphology. So look at the P wave here. Medium in height, dwarf. This one is a bit taller. In fact, it's even the tallest. And it's thin. This one is a bit horrible, like you just start seeing different morphology. That's what I just want to bring out for you. You can see this one. See, that's how you'll be seeing them like that. When you see this, don't say the ECG is complex. Just say I'm seeing different P wave morphology, and this patient has COPD, or this patient has something that is making the patient to have just one cardiopulmonary condition. It can be heart failure. It can be one condition causing all manner of stuff. So, and you now see this ECG there. Just go for multifocal atrial tachycardia. In fact, it has, you call it MAT. So MAT. All right. We all know mathematics. What do you do in mathematics? Anybody? Don't say Festus, don't trouble us. Just say it. What do you do in mathematics?
Calculation.
Someone say board mass. How come it's board? So we calculate. So this is your treatment. So your treatment is going to be calcium channel blocker, not dilopyridine calcium. So you must never forget that again in your life. So when you see multifocal atrial, you now say math. You don't even think about it before you say it. You just use calcium channel blocker. And the person that say board mass, maybe we can put that your board mass under beta blocker. So that is math. Multifocal atrial. Now, if the patient is coming acutely, you give intravenous, because I don't think that in our practice in Africa, when you see acute condition, you give oral. It's not something that is common anyways. So you give intravenous treatment, drug. Then if it's now more or less like it's becoming chronic and the like, so you now change it. Immediately you are done with that acute presentation, you now change to oral. So that's the treatment. But there is also a caveat you must look out for. in the exam. What is that caveat? The first thing they will be looking for, they are most likely going to test about the treatment, is this underlying condition. Treat the 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 underlying condition. That's the most important treatment here. Treat the under is the first step. This is the first step. Treat the underlying condition. Then you can now be going to drugs. So I needed to link the math with calculation for you, Carl, for you, so that you will not forget the name of the drug, because I'm already mentioning quite a number of drugs. So math, Carl. All right. So please don't forget that. Yeah. So let me show you a question just for you to have an idea of how this could be. So 72-year-old man with history of COPD presents to the main department with rapid palpitation, this now, because that's how you will be seeing them, and all of them will now look alike. All of them will now be looking alike and be like, yes, what kind of dick is this? I hate ECG. I hate ECG. His vital signs include heart rate 140, respiratory rate 24, blood pressure 138. See, oxygen saturation 92. ECG is showing multiple P wave of varying morphology with an irregular reading. So immediately you see this P wave of varying morphology, and you see a background history of COPD, and what else? Now see, which of the following is the most likely cause of this arrhythmia? You already know what you are dealing with. That is math. And that's all. So look at this one. 65-year-old woman, history of COPD, heart failure, present with palpitation, shortness of breath, fatigue. On examination, she is tachypneic. Heart rate is 135, blood pressure 110, 70, oxygen saturation 90. ECG show a rapid, irregular reading with P wave of varying morphology. There is no distinct PR interval. You now say the rate is more than 100. Which of the following is the most appropriate initial treatment? All right. The most appropriate initial treatment you will be looking for in the exam is to address the underlying condition. So if that is not there, if they are mentioning drugs, you now go for the drug. So which drug do you want to give? You give calcium channel blocker. Wait. What about the beta blocker? Beta blocker is there. You need to be very careful prescribing beta blocker in a patient with all the COPD and the likes. You need to, and also heart failure. You need to be very, very careful. Most especially if the patient is already decompensating. You need to be very, very, very careful. So that's what before you give beta blocker, you need to assess the patient, whether the patient can take that beta blocker or not. But beta blocker is a very good drug for this math. Do you get it? So at least don't forget the calcium channel blocker, and please don't forget that no hydroperidine calcium channel blocker. Then you come down to what we call the ventricular tachyarrhythmia. If you look at all what we've been able to look for now, we looked at what we call the supraventricular tachycardia. Now we are looking at ventricular tachyarrhythmia now. All right. So the first one, there are actually two of them. The first one is premature ventricular contraction, PVC. So premature ventricular contraction. We also have premature atrial contraction, PAC. So this PVC is the one the first aid is saying you must know very, very well, which is true. But in the exam, they've tested the PAC. So PVC, PAC. I will tell you the questions you are expecting. Like, just expect any of those questions in the exam. If you like, say we are liars, say you believe. So just take note of them. Beyond the exam, it will also help in the practice. So when you are reading the literature and you see them mentioning PVC, you have an idea of what is going on. And when you see the ECG, you can easily pick it because it's very peculiar. So it's premature ventricular contraction. That is full meaning of PVC. Look at this ECG. So what this premature ventricular contraction basically means that it's not yet time for ventricles to contract, but it just contracts, but there is something. So if you look at the contraction, that contraction is not preceded by P wave. Because in a normal sequence of the ventricular contraction, atria will first of all contract, then the wave will flow through the AV node, come to the ventricles will now contract. But in this one, the ventricles are contracting prematurely. Information has not gotten to them, they are contracting. Who is supposed to bring the information? P wave. So there is no preceded P wave. Then you now see the ventricle. See the way the thing is like this. That is how all the premature ventricular contraction are most likely going to look like. Most, and I choose my word carefully because some of them may have something different. But in this exam, you are going to write. If they will give you PVC, this is how it's going to look. And you can see the QRS complex here is wide. So you won't miss it. You can see this normal KRS, normal KRS, normal KRS. Now see this one very big and wide. That is premature ventricular contraction. There is something else that will follow this contraction, and that is a compensatory pause. It's like you are talking turn by turn, and someone now talks when it's not yet time for the person to talk, and you now shout at the person, it's not yet your time to talk. The person will keep quiet. Compensatory pause. And when the thing eventually gets to him to talk or her to talk, the person might even feel reluctant to talk, just for you to have an idea of how you can quickly link it, just in a way that you will understand. So it's contracting prematurely, and there is a compensatory pause. So when you check this area, you will not see any P wave or anything. It won't be. So you just see this area of pause there. But this big one, we give it out in the exam. That's a very good one. How will I differentiate this from premature atrial contraction? Premature atrial contraction does not usually have this compensatory pause, and you will not see this wide, big QRS complex. You will not see that one there. You won't see that one there, even though the causes may look a bit alike. All right, so but you won't see this. This one is very peculiar. The way it looks, that's how it's going to be given in the exam. You just pick your premature ventricular contraction. All right, I put something here. Your duty is to search the question to see the premise of the premature ventricular contraction. What is causing it? Now, let me show you. It can be caused by electrolyte problem, hypokalemia, hypomagnesemia, hypoxia, fibrosis, reduced liver function. Keep naming them. But you know, the things you can easily miss are this electrolyte problem. They say this patient is having diarrhea, and this patient now develop maybe just have this palpitation. You now do the ECG, you see this premature ventricular contraction, and you are now like, what is causing it? Well, this patient has been having diarrhea, losing potassium and the like. So this patient has been on diuretics, losing electrolytes. So that could be the cause, electrolyte problem. If in the context of ischemic heart disease in that exam, you see this, it is a sign of impending doom. If you look at the two scenarios, they are different. Someone having diarrhea, develop hypokalemia, hypomagnesemia, hypo this, hypo that, having this kind of ECG, you look and nod your head and tap the patient at the back and be like, you will be all right. But this patient has ischemic heart disease, and you do ECG, you see this, you don't tap anyone, you tap your head. Something is about to happen. The next time you are going to see the patient may be dead, because it is a sign of impending serious arrhythmia. A very good example, ventricular fibrillation. Ventricular fibrillation in a patient with ischemic heart disease. Can you see the two ways you are looking at it? So if you now see it in a patient with electrolyte problem, correct the electrolyte and the patient should be fine. If the patient is having hypoglycemia, give the patient magnesium, the patient should be okay. But in a patient with ischemic heart disease, place the patient on beta blocker, because or else the next time you see that patient, the patient is dead. All right. So, and you will now be thinking it is the ischemic heart disease that killed the patient. Yes, it could be, but it could be the arrhythmia that will follow this PVC that killed the patient. Can you see the way? So when you are reading that question, you are not reading it in the context of, I know there is something called PVC. You are reading it in the context of, I know how to identify it and I know what I'm thinking about. All right. So in PHC, it can be caused by caffeine. It can also be reduced by caffeine. Do you get me? All manner of things can cause, even the PHC, all manner of things can cause that one too. All right. So that's about this. Let me show you one or two questions just for us to have an idea of how this could be. Really nothing much question anyways. 28-year-old present to the mind department, palpitation report. Palpitation started suddenly while she was watching TV. Her vital sign within normal limits. ECG show premature wide QRS complex, since with no preceding P wave. It's premature. So P wave is not the one dictating. It's not the one, you get that? Followed by compensatory pulse. They now ask you what is the diagnosis. You can see wide QRS complex. Once you see wide QRS complex, or any arrhythmia coming from ventricles will be wide. Any arrhythmia coming from the ventricles will be wide. All right. So let's look at this second one. 45-year-old with history of hypertension, smoking, ECG show premature wide QRS complexes, each followed by compensatory pulse. His symptoms are mild and is otherwise asymptomatic. They now ask you that what do you want to do for this patient? You just monitor, you follow up the patient. But let us assume that this same patient has history of ischemic heart disease. You don't observe. You need to commence the patient on beta blocker. So the answer will be A. If this patient has prior history of ischemic heart disease, whereas you reassure if there is nothing like that. What if we have multiple of premature ventricular contraction? Multiple of them. Multiple. Then we can peg that on ventricular tachycardia. It's no longer one. There are now many. Ventricular tachycardia. All right. Ventricular tachycardia. QRS complex here also will be very wide. P wave. You won't see any P wave. The ventricles are just contracting at a very high rate. All right. Okay. So, ventricular tachycardia. You come down, you see a wave of ventricular, you see ECG of ventricular tachycardia like this. The possible question that will follow it will be, how do you want to treat? And I will show you how you do the treatment. Before I come to the treatment, let me also mention ventricular fibrillation. Look at the ventricular fibrillation. You can see it is chaotic. There is no orderliness here. However, in ventricular tachycardia, you can see the order. You can see the regularity in a way. Check the ventricular fibrillation. You don't even know what is. No discernible rhythm. Nothing. All right. So how are you going to be treating these two bastards? How are you going to be treating these two bastards, including the ones I'm going to mention very soon? How are you going to be treating this? There is what we call CPR. I'm not saying you are going to use CPR to treat though, but there is something called CPR, cardiopulmonary resuscitation. There is a premise for that. For those that have been doing it, you check out for something. You see this patient lying. Help. Hello? Can you hear me? The person is not talking. You check for the pause. You check for the pause. That's the next thing. If there is no pause, resume CPR. You start doing chest compression. If you can feel the pause, don't go and compress anybody's chest. You don't press anybody's chest. So if the reason I'm mentioning that is for you to have an idea about, in case they come here and they are putting what do we call it? They are putting CPR and all manner of stuff in the question. You don't go for CPR usually when there is pause. Don't even go for it when there is pause. You don't go for it. You don't initiate that. Now, when you see this kind of rhythm, you check for stability again the way you've been checking for them. If the patient is stable, lap the patient. Lidocaine or amiodarone or prokinamide. But at least don't forget lidocaine. If this patient is not stable, you now assess for the pause. If the patient has pause, synchronize cardioversion. The same way you have been treating other people. Because it is at this point we are now talking about, is this patient having pause or not having pause? Because this is a problem. All the other ones we've been talking about, we never mention anything about pause or no pause. So if there is no pause, it's pauseless, and you have this kind of rhythm, bastard rhythm, defibrillate the patient. That's the answer. Defibrillate the patient. Where you are now going to start with the other stuff I will show you very soon. In fact, I think I should just quickly show you. So I'll quickly link them all together. Now, I want you to look at this. This is the management of cardiac arrhythmia. We have these guys. Asystole, pulseless electrical activity, what do we call it? Ventricular fibrillation, pulseless ventricular tachycardia, and the likes. Anytime you see a patient, there is no pause. What you are going to do normally in the context of CPR is just to start the CPR. So if you look at the question very well, you are looking at this question and you are like, wait, this patient has no pause. So that pause, you now focus on it very well. This patient has no pause. You are going to be more or less like, let me initiate CPR. That should be the normal response. Do you get me? But don't forget something, that your main goal is actually to defibrillate. Once you know that the kind of what is causing it is actually all this abnormal abnormal rhythm, you defibrillate. Now, the way USMLE will now test you on this is in this area that I put my arrow on. They know you know CPR. They know I want to defibrillate. They know all those stuff. So they are going to test you on what you do now. After doing that thing, what will you do next? Now, let us go one by one. You check the question. This patient is not having any pause. Immediately initiate CPR. Because that's what everybody will do. Initiate CPR. I'm dealing with ventricular fibrillation or pulseless ventricular tachycardia. Initiate CPR. As you are doing it, you are going to request for this defibrillating machine or defibrillation machine. Someone should go and get it. If at all it's hanging around, someone should go and bring it, which means that is your main focus in a way. So you initiate CPR when there is no pause. Now come here. You have initiated CPR. They will now ask you, what do you want to do next? You are now going to use this mnemonic. D2 Edade. I don't know if I thought you can pick that. For those that are Yoruba, it will be easy for you. Edade. not Adeda, not Asheda, not Ede, Eda, De, D2, Eda, De. What is the first D? Defibrillate immediately. Clear? Again. Can you see the way you do it? Again. Defibrillate again. The next thing, the patient is not responding. Is not responding. Epi. That is the E. Epinephrine. Need not coming. Defibrillate again. B. All these arrow that you see here, they represent CPR. All these arrow, in between them, you are having CPR. 5 cycles of CPR. Can you see? CPR. You still continue it. You are not stopping, despite the fact that they say the machine is here and the line. You don't stop. So the sequence is what they will test you on. So you give the first one, boo, continue. Give the second one, boo. That's the defibrillation. I'm not seeing any response. The next thing, what do you want? The question asks, what's the best next step? You now go for epi. The question says they defibrillate first time, second time, they've given epi. What is the next thing you want to do? You want to defibrillate again. Oh, they've done this. You just be following the sequence. What have they done? So if you don't have this mnemonic at the back of your mind, for those that have not been doing it, it might actually be a bit difficult for you to find your way around it, because the question will look a bit complex, that you might not really be able to find your way around the question. Do you get me? So that is for this. For the asystole, there is no contraction. No contraction, or you are not seeing electrical activity at all. In this regard, let us give the patient contraction. Give epi. Yeah. Can you see the difference? You give this patient epi or vasopressin. Asystole, that's why I put it as initiate CPR. Why am I initiating CPR? There is no pause, which is the normal reason why you initiate CPR. Then when you eventually know the the ECG pattern and whatsoever that is going on, you give your epi or vasopressin just to initiate the contraction. All right. Supraventricular tachycardia, you already know how to treat this. Atrial fibrillation, you already know how to treat this. So these two are not the problem. These are the two that are now new to you. Let me show you a question. Possibly you will be able to have an idea of what is going on here. I hope this. So just let us look at this. 55-year-old woman loses consciousness in the emergency department 1 hour after being admitted to the hospital for sharp acute chest pain and diaphoresis. There are no palpable pulses. Chest compressions are started, which is CPR. Medical history is significant for type 2 breast cancer that was surgically treated 4 years ago. Prior to admission, the patient was on a long bus ride to visit her sister. Her medication include tamoxifen, atorvastatin, metoprolol, and the likes. The cardiac rhythm is shown. Which of the following is the most appropriate next step? So let us look at the ECG they are giving. So I just want you to look at it and say what you feel the ECG is. What do you think this patient is likely having? So the way I want you to look at it is when you get into the exam, the way you look at it is this. Do you think there is anything ventricular about this patient's problem?
No.
So what do you see in that question that is making you to think there is nothing ventricular about this patient problem?
No.
It's
Why?
more, it's
Eh?
more block bradycardia.
So
There's no
look
white
at
cure.
There's
look
no
at
white
No
PRS
discernible
complex.
P wave.
exactly. That's
No white
actually
PRS complex.
exactly. There is nothing like wide QRS complex. This QRS complex is looking okay. Then what else again? Look at the heart rate. The heart rate is very, very, very low.
Yeah.
The heart rate is very, very low. So, what do you think this patient is likely having?
Sinus breath.
So, do you
Atrial
see anything
fibrillation.
like P wave
No P
here?
wave.
No P wave, right? Look at this. Do you think this is a P wave? 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 Likely to be a P wave. Likely, I say. But the heart rate of this patient is very low. And this is actually where your brain work is going to start. Now, you can see bradycardia in a patient that is 55, losing consciousness. What else do you see here again? What do you think is likely causing it?
Hay fever.
It's on drug now, beta blocker.
Beta blocker. Maybe this patient is taking overdose of beta blocker. Maybe. Right? Maybe this patient is taking an overdose of beta blocker. It could be. It could be because the heart rate is very, very low. So if you are dealing with overdose of beta blocker, which drug do you normally use to treat that?
Gas then. Glucagon.
You can actually
Atropine.
give the,
Glucagon.
yeah, can give the glucagon. So that's all we could see there so far. We can't see anything ventricular. I don't think that's a very good question. Let's see. I hope that is very correct. Sometimes I make mistake in the ECG. Let's check for another one. I'm coming. This is rubbish. I'm coming. Look at this. Let's see the ECG. ECG 22. If it's not ventricular, so this one is looking like torsade. Come. If not done this. Is there no ECG here? Okay. All right. So I want you to look at this. The monitor shows no. Okay. Maybe there is no any ECG here. Just let us look at this one. 75-year-old man becomes pulseless in the wait. Come back to this question. They are very correct. They put something in the question, we ignore it. Look at this. And that's why we need to be very careful. There are no palpable pulse, but we can see an electrical activity there. Do you see it? And that is actually how the thing is going to come. Thank you. So that's how the thing is going to come. You check the ECG. You are seeing, I can see something here now. But you check the pulse of the patient. You can't feel any pulse. That becomes pulseless electrical activity. Do you get it? Then another thing again is that if it's going to be the beta blocker overdose, it's most likely going to prolong the PR interval. But that PR there is looking not, I don't think it's beyond 5 small boxes. Do you think? How many small boxes can we count here? I don't think it's up to 5. 1, 2, 3. It's like 5. So not likely to be the beta blocker overdose. We can see an electrical activity, but there is no pulse. That becomes pulseless electrical activity. So the question will now be like, what do you want to do? Have they started CPR in these patients? They've already started CPR. Chest compressions are started. The next thing is now, what do you want to do next? So your answer will now be something like what? Vasopressin or what? Epinephrine.
Epinephrine.
You see the way you look at it. I think there is also, look at this one now. I want you to apply this knowledge to this question. So you pick it now. A 75-year-old man becomes pulseless in the cardiac ICU 48 hours after admission for ST elevation MI. Blood pressure very, very low. The ECG monitor shows a tachycardic irregular rhythm with erratic undulations, but no discernible P waves or QRS. During immediate advanced care life support, 2 attempts at defibrillation are made, after which the patient is given 1 milligram of IV epinephrine. After a third attempt at defibrillation, the patient remains pulseless and his blood pressure is still low. The ECG monitor shows no change. Administration of which of the following is the most appropriate next step? So what is the answer?
Amiodarone.
Do you all agree it should be amiodarone?
Yes.
Okay, write down your D A D E. So write it down and now see which one. So when you get into the exam, you will now write D E D A D E. Do you get it? So as you are reading the question, you are crossing the ones they've done. You've done the first one, you've done this one, you've given this, you've given this. I think they stop at the third defibrillation, right? So your answer will now become what? Amiodarone.
Yeah.
Do you get it? So now, let us assume that the question says they've given amiodarone. So the question they will give Dr. A might be that it's stopping at the level of amiodarone. The one they will give Dr. B might be that amiodarone is already given. What do you want to do next? Do you see the way? That's why you need to understand what you are doing and not just depend on what are they saying. All right. I think you've gotten that. Let me go back a bit to where I was coming from. So now, you understand how you look at this one now. Ventricular tachycardia. You check for the stability of the patient. If the patient is stable, lap them. If the patient is unstable, you check for the pulse. If the patient has no pulse, defibrillation. But don't forget, you start with CPR and the like. But your main goal is to defibrillate the patient. And don't forget that sequence. Do you get me? Don't forget that sequence. If the patient has pulse, synchronized cardioversion. Ventricular fibrillation, just go and defibrillate straight up. This is torsade de pointes. You can see this undulating pattern. You can see it. And you can see QRS having different height and shape. That's why you call it polymorphic QRS with variation in amplitude and cycle length. So you can see that's torsade de pointes. You have so many things that could have caused this, which is fine, but amidst all of them, don't forget electrolyte problem, drug problem, long QT syndrome. Do you remember the long QT syndrome? Do you remember them?
Yes, sir.
Okay, so don't forget them. Which one has deafness in it?
Javel nonsense.
So don't forget that. So the Romano word, you can hear a word there. So that one has no deafness. Don't forget that. Okay. So you check for the electrolyte, but in the hospital, when you get into the hospital, for the torsade de pointes, when you see it, the drug of choice, they must hear you shouting on top of your voice is magnesium. Max. Don't forget magnesium. You just need to give the patient magnesium and the patient will be awesome, will be fine. That's the initial drug. So that's the initial drug. The same way you look at it, if the patient is pulseless, just like the same way and this is, what do you call it? Torsade de pointes, the patient is pulseless. Do you get it? You need to give the patient defibrillation. Don't forget, like defibrillation, because on a normal, if you are walking on the street and you see someone collapsing and you do, hey, help, what happened? Hello, can you hear me? Okay, so you start your CPR, you check for the pulse, and the pulse is not there. Immediately, the next thing you do is to what do you call it? Check for your pulse. The pulse is not. You start your CPR, and you try to send for the defibrillator. Do you get me? So, which means that the defibrillation is one of the key things that you must do. That's why in the United Kingdom and around, you see them having defibrillator around, even on the streets in some special areas, and the people around those areas, they know, and most of them actually know how to use them, because I remember even people that don't know anything about medicine, they know how to use it. They train them. For those that are in Nigeria, I don't know how rich most of us are. You can actually take it up as a project and just put different. Just that someone will say they will steal it. I think we need to start looking beyond our problem and start seeing solutions. Because when you focus on the problem, you will not do anything. But when you focus on the solution, you are most likely going to do something. It might even just be in your town, and you just be like, let me train 2 or 3 people, young people, how to use a defibrillator, and you just show them how to do CPR. You don't need to have certificate. You don't need, just train them, and you record it. Take picture with them. Put it on this thing on your platform, on your social media. Let everybody see how wonderful you are doing. I said something last time. Don't be too humble. You need to be proud. In fact, you need to be proud. If you are not proud and bragging, you are not going anywhere in this life. If you like, shout Jesus from the beginning, from the morning till night. Your movement is going to be limited. Do it. Put it up. Say something. I have done this. Just let everybody know. Put them in those strategic places. Train them and let us see. They might not use it in the next 1 year, but the day that thing is going to save someone, the whole world is going to know. So that's just by the way. Let me show you a question here, if possible. All right, so look at this question. 2 days after being admitted for pneumonia, a 70-year-old man has repeated episode of palpitation and nausea. He does not feel lightheaded and does not have chest pain. The patient appears mildly distressed. His pulse is 59, blood pressure 110/60. Examination shows no abnormality. And sputum culture taken at the time of admission were positive for mycoplasma pneumonia. His magnesium concentration is 2 and his potassium concentration is 3.7. An ECG is taken, which is showing torsade points. You can just use that ECG taken during an episode of palpitation. Which of the following is the most appropriate next step? Now, this is it. So immediately you see torsade points is here, and you check this patient. You check for the stability in a way. All right, this is all about drugs. Which drug do you want to give, and all manner of blah 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 and the likes. Your drug of choice is magnesium. Write it down. Note it now. It's magnesium. You give the patient Magsolve. You give the patient, whether the magnesium level is normal or abnormal, you give magnesium. You give magnesium. So when you get into the exam, don't be carried away by the value of magnesium they will give, whether it's normal or it's not normal, whether it's low or not. You still give that magnesium. In fact, this 2.0 is even like maybe at the upper limit of the normal. I don't know what the normal range is. You can go and confirm. So you still give the magnesium. Immediately you see that this is torsade points. So please never forget that. So you can see that pathway I was trying to talk about. So you can see the slow pathway and the fast pathway. So I come down to atrial fibrillation. So what is going on in atrial fibrillation? I know you know it though, but let me still show you some stuff. All right, atrial fibrillation, which means that the atria are actually fibrillating. They are just vibrating. They are not really contracting the way you expect the contraction to be. Now, thank you so much, Festus. I know atrial fibrillation, but what would they be asking me in the exam? Now, let us go step by step for each area each of the questions you are expecting. Let's organize them. The first one is about the risk factor. That's the beautiful thing about first aid. So you see, if you don't understand the way a book is written, don't inferiorize it. The book is well structured. Expect question on risk factor, and it will be tested. Now, what are these risk factors? Hey, hypertension, increase age. Hypertension, increase age. Now, how will that one now come? When you read that question, you will not see anything. You will not see anything other than the age of the patient. They will now say, what is the risk factor? You can't see anything. They just say 170-year-old man admitted for atrial fibrillation, this one, that one, blah, blah. Which of the following is the likely risk factor? The patient does not have hypertension, does not have this, does not have that. Which of the following is the likely risk factor here? You will now be wondering, I don't understand what they are trying to test. Age, increased age. That's the answer. Now, if they say this is maybe 50-year-old or whichever age, they now say the patient is a known hypertensive, develop atrial fibrillation, admitted for this, blah, blah, blah. Which of the following is the most likely risk factor? The answer is hypertension. Can you see the way you are doing your thinking? I can't say hypertension, increase age, if that age is the obvious thing. I can say hypertension and increase age, pick hypertension. It's a silent killer. So that would be the answer, hypertension. So I put an arrow on it because it's very high yield for you to note. The next thing is this. There are we also have this heart failure. And let me say something about the heart failure and valvular disease. There is another condition you must put at the back of your mind that causes, or set of conditions that can cause atrial fibrillation or fibrillation generally. Fibrillation, whether ventricular fibrillation, atrial fibrillation, it is actually chamber dilation. If the right atrium dilates by one reason or the other, atrial fibrillation will develop there. If the left atrium dilates by one reason or the other, atrial fibrillation will develop there. If the ventricles should dilate, ventricular fibrillation is most likely going to develop there. So now, the first question. What can make right atrium to dilate? Your answer will now be tricuspid stenosis. So, can tricuspid stenosis cause atrial fibrillation? Yes, it can cause it. The next question, mitral stenosis. Can mitral stenosis cause atrial fibrillation? Yes, because the left atrium will also dilate. Aortic stenosis, pulmonary stenosis, when those things dilate, they can. So sometimes what kills people in congestive heart failure is not the heart failure itself, it's arrhythmia. Because those chambers dilate, so they can easily develop arrhythmia. And the thing will just develop, and the patient is dead. And I say, is that heart failure? Dead. Second, but it has occurred, it has come, it has gone. Nobody will pick those kind of death. Which autopsy is going to show the arrhythmia? Nobody will pick it. You can only peg it on the primary cause, the heart failure. But sometimes what killed them is actually beyond the failing heart. It's actually the arrhythmia. So in this exam you are going to write, any question you see where there is a chamber enlargement, what the patient is at risk of is arrhythmia. You must put that at the back of anywhere, any question. You see, the chamber is enlarged. Now, see which of the following is this patient at risk of? You see arrhythmia there, that is the answer. The next thing is that when you see atrial fibrillation, you want to rule out some factors, reversible causes. I say she must be excluded. She must be excluded. Any patient you see, maybe a young patient, the patient develop atrial fibrillation, you are clicking the patient, she must be excluded. So what are these she? S, substance abuse. Substance abuse. Are you taking caffeine? Are you on any particular drug? Are you taking these? Keep listing all the drugs that the patient can abuse. For all you care, if that substance is not brought out, you will treat the patient and the patient will still go back to it and die of it. She must be excluded. Substance abuse. H, hyperthyroidism. That's the next thing you must exclude. Any question on atrial fibrillation you see, they must exclude them. If they do not exclude them, that will be your next best step. How are you going to exclude hyperthyroidism? You exclude that by doing what you call TSH. So can you see the way you are reading the question? Yes, this patient has atrial fibrillation. Have you excluded she? Check. Any substance? No. What is the TSH? It's normal. What about electrolytes? Now check the question carefully. Any electrolyte derangement? Because for all you care, that might be the cause. So from today onward, for those that are not used to this, any question on atrial fibrillation you are reading for step 2, she must be excluded. If they have not excluded she, that will be your answer. That's about the risk factor. Just for us to have an idea of how this could play out, these are the other stuff. Now, look at this question here. Look at this question here. 72-year-old man with a history of hypertension, history of hypertension and diabetes mellitus, present with palpitation, fatigue, lightheadedness for the past 2 days. Blood pressure is very high. BMI is 32. On examination, irregular pulse is noted. ECG show atrial fibrillation. Which of the following is the most significant modifiable risk factor? You've forgotten modifiable in the name. You are like, advanced age. They are not saying you are not correct. You are very correct. But advanced age is not modifiable. You can't modify your age. You now quickly check that question. Can you see any other thing that can be modified? That could be the cause. BMI, obesity. The patient can cut down his weight. So that's how you'll be looking at. Let me see. Look at this one. 65-year-old woman with a history of COPD. Present with worsening dyspnea and palpitation. She denies chest pain or syncope. Vital signs are notable for irregular. ECG shows atrial fibrillation with rapid ventricular. Which of the following conditions most likely contributed to her development of atrial fibrillation? What do you think is likely contributing to this patient's atrial fibrillation here? What are you going to go for? You can see COPD. You can see, what else can you see here?
COPD.
So for now, we are just going to assume that it's likely the COPD that is causing. We can't go for hyperthyroidism because there is nothing about hyperthyroidism here. And the question is not about we should exclude it or something like that. So COPD. So that's how you are going to be looking at the question and the likes. So I want you to look at this one. Let us see if you can bring this one. 50-year-old man present with a routine checkup. He has a history of alcohol use disorder. Drink approximately 5 to 6 drink daily. Vital signs normal. He has no symptoms. ECG is incidental review atrial fibrillation. Which of the following is the most likely contributing factor? So what will your answer be here? What do you say? Alcohol. Most likely is the alcohol.
Alcohol consumption.
Exactly. That's how you are going to be looking at it. So most of the time, what you are looking for will be in the question. But don't forget the question that will show you how you are going to. I will show you those questions down here. She, just know that she must be excluded. Pathophysiology. Now, with respect to the pathophysiology, I've already told you about some of them. Dilation of the chambers. Do you get it? All this valvular problem will also predispose, because those valvular problems will predispose to the dilation of the chambers. The next one is this irregularly depolarizing cell near the ostia of pulmonary vein. Pulmonary vein usually empty into the left atrium. Around that pulmonary vein, you can have this irregularly depolarizing cell that usually give birth to this atrial fibrillation. So you must note it. This is a very wonderful one that you must not know. So how do you classify it? There are ways of classifying it. You can classify it into valvular or non-valvular. So valvular ones means that there is a valvular problem. Do you get? There is a valvular problem. Valvular problem. Do you get it? That is predisposing to this atrial fibrillation. Non-valvular means that when you check that patient, there is nothing like valvular problem. Maybe valvular stenosis. You can't have anything like that there. And this is a very wonderful classification that I will advise you to use in the exam. This is the one they are even going. The question is even most likely going to revolve around: is it valvular or non-valvular? Do you get it? Now, the history. You already know how the history will be. Patient with ECG with no P wave, with or without chest pain. That will be the history. Do you get it? Palpitation, fatigue, dyspnea may be there. They may not be there. The patient can even present with thromboembolic complication like stroke. Now, wait there. Festus, did you compare atrial fibrillation to something previously? I say yes. Which one? AFib-NRT. AFib-NRT has no thromboembolic complication. AFib-NRT has no thromboembolic complication. However, atrial fibrillation has thromboembolic complication. Do you see? For the AFib-NRT, don't forget the pulse is going to be regular. Atrial fibrillation, irregular one. So don't forget. Now, all right, so don't forget, that's why I put an arrow here. This thromboembolic complication, which means that when we are treating, we need to factor this one in our treatment. So now you come down to investigation. The exam is all about orderliness. So when you get to this investigation, when they want to test it, the question will say that the patient has done ECG. They've seen the rubbish. They will now say, what is the best next step? The best next step is the lab. And someone say first aid is rubbish. Yeah, I will look at you and laugh in Spanish. It's already given. This is what you are taking into the exam. Have you done ECG? They say yes. The best next step is the lab. That's your answer. The question say ECG is done. Lab is done. The answer, what's the best next step? The answer is transthoracic echo. And that's all. So when you are about to go into the exam, you revise this trend. How are you going? Have you done ECG? The question says yes. The best next step will be the lab. And what are you doing in the lab? Electrolyte. First of all, don't forget those sheep. So substance abuse, if at all there is a way you can screen it. Screen for if you are suspecting it. Hyperthyroidism, TSH will give you an idea of that. Electrolyte, you need to do electrolyte. Complete blood count could also be done. But don't forget those she. Lab, she, lab. If the question now says the lab has been done, what is the next best step or best next step? The answer will now be transthoracic echo, or they just put echo there. What are you trying to look for in the echo? You want to check for atrial enlargement. You want to check for valvular problem. You want to check if at all there is already a thrombus. Already being formed somewhere. Or embolus. So that is the order. Let me show you one or two questions here. Okay, look at this question. Sorry. I don't know what's going on here. Look at this question. A 65-year-old man presents to the mining department with palpitation, shortness of breath, for the past 2 hours. He has a history of hypertension, DM. On examination, his pulse is irregular, blood pressure is 140/90. Immediately you are seeing irregular pulse, and like you're already suspecting atrial fibrillation, and ECG confirms atrial fibrillation with ventricular rate of 130. The question now says, which of the following is the most appropriate initial investigation to evaluate the underlying cause? You are now going to ask yourself, wait, have you done ECG? The question says you've done ECG. Then your best next step will be the lab. You now check through all the options. Which one is which? If you look here, you can see serum electrolyte. You can also see TSH here. So you have 2 labs that are very, very obvious here. Which one are you going to pick? Most likely one you are going to go for, write it down now, is what? Which one?
TSH.
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 Never forget that. TSH. So let us assume that we check the TSH is not there. You now go for the serum electrolyte. Do you see the way you are doing your thinking? So you won't say that oh, this is not, because some people actually have hyperthyroidism and they will not know they have it. So TSH. So don't forget. Then unless maybe they put some other premise in the question that is really revealing why TSH should be maybe one electrolyte problem that is very apparent. Do you get it? Let me look for another one here. We've not done Charles. Look at this one. 58-year-old man with history of obstructive sleep apnea, obesity, diagnosed with atrial fibrillation during routine checkup. He denies any symptoms. Initial laboratory tests reveal normal renal function, normal thyroid, no electrolyte abnormality. Which investigation is most appropriate to screen for structural or functional cardiac abnormality? So which investigation is that?
Transthoracic echo.
CTA. So that's how you will be looking at all of them. Yeah, echo. So that's how you'll be looking at them. Look at this one. 75-year-old man presents in the emergency department with acute onset palpitation, dizziness, ECG shows atrial fibrillation with a ventricular rate 140. Initial lab is now given. So you can see TSH is normal, potassium is a bit low, serum magnesium is, you can check for the normal of all these ones. So you can check for the normal rate for magnesium. What is the next best step in the investigation or management of this patient? So what's the answer?
Perform transesophageal echo.
You see the way you are saying it like you wrote the question. So that really makes sense.
CT.
So wait. See, which of the following best is the best next step in the investigation or management of this patient? So you can actually first of all just check for all these stuffs. You know, it is when you don't see the abnormality in the, what do you call it, electrolyte, you go to the echo to go and check for structural problem. So you can check for this one, but that really makes sense. I love your answer. That answer is very correct. But here, please, what is the normal level for magnesium and what is the normal level for potassium? Help us to check it. I think potassium should be 3.5.
That's a sweet boy. Did you return your
Right.
print?
What of
3.5
magnesium?
to 5.
Yeah, what of magnesium?
1.7 to 2.4.
What do you call it?
1.7 to 2.4.
So you can see the problem. So this patient is having an electrolyte problem, right? So because the patient is having an electrolyte problem, just correct the electrolyte at that level. That makes sense.
Mom,
I think
this
So let us assume, if we assume, help us meet your mic. So if we assume that the electrolytes are normal, then I'll say that what's the best next step? Your answer will now be something like B. Now, beyond this, even though the electrolytes are deranged and you've corrected them, it's also still important for you to do the transthoracic echo. Do you get me? Because for all you care, the patient might have already been developed one clot or the other. Do you get it? So you still go ahead and check for all those stuffs. All right, so that's fine, but correct the electrolyte. I think those are just the questions I have there for you to have an idea. Now, you come down to stroke prevention. So how do we prevent stroke here? the way we prevent stroke. Okay, let me quickly show us how we. All right, let me quickly show us before we go. So the way we prevent stroke, we usually use a score. We call it Charles-Fast score, but I just call it Save Charles. Let us save Mrs. Charles from stroke. That's why I look at it. Let us save Mrs. Charles from stroke. So if you look at this SAV, it can be any of these guys anyways. Sorry. So it can be any of these guys anyway, but you can look at the S as the stroke, or TIA is 3, you give it 2. A, like 75 and above of age. V, vascular disease. Then Mrs. Do you know you might not even really bother yourself about charts before you before you pass that question? You get the question right, answer right. So you just check, do you even have any stroke before or something like that? You say no. Do you get it? Or TIA is 3? No. So 2 score is not there. Age, how old is this patient? So if I can see the age of the patient, you know, every history we start with the age and the gender. So what is how old is this patient? They say the patient is 76. What is the gender? The patient is a female. I already have 3 points. Once you have 3 points and above, then the patient needs to be on anticoagulant. I don't even know the other factors. I don't know. I just get into the exam and I remember age and gender. How old are you? 75 and above? 2. What is your gender? You are a female. 1. I add them together, making 3. So I'm already thinking that whether, even if you don't know any other thing again, this patient will need to be on anticoagulant. Can you see the way you look at it? Then there are some common things that we all know that we have in the history, past medical history. Diabetes, hypertension, these are all going to be 1-1. Are you diabetic? Are you hypertensive? Once you see this, 1-1. Do you see? 1-1. If the age is less than 75, that is going to be 1. So let us now assume that I see a 50-year-old woman. I already have 2 points. Who is hypertensive? 3 points. And diabetic, 4 points. The next thing is this patient must be on anticoagulant. Do you see do you get the idea? Do you get the gist I'm trying to show you? Do you get the gist?
Yes, sir.
Okay.
Yes.
All right. So you don't need to cram everything before you master what you are supposed to master. Even from the age of the patient and the gender of the patient, you can just be like, this patient, they are just presenting to you. This is 77-year-old woman who is diagnosed. The next thing you say is, hope this woman is already on anticoagulant. And they are like, you didn't even allow me to finish. Yes, I know you know the diagnosis, but you are just saying, hope this woman is on anticoagulant. And you are like, no, we've not commenced. The next thing is why? Why haven't you commenced? This patient needs to be on anticoagulant. Because from the age and the gender, you already know the score. At least 3 in women and at least 2 in men. Do you get it? All right. So hypertension, diabetes are common things. Just give them 1-1. Stroke, age, 2-2. By the time you are adding them, you are already getting up to like 7. You don't need to get up to 7 before you say you know what to give. Now, what are these anticoagulants you are going to give? We have the direct oral anticoagulant. Direct oral anticoagulant or warfarin. These are the 2 basic categories of the drug you will be given in the exam for the patient. And that is where your questions will revolve around. Do you want to give DOAC or you want to give warfarin? If the patient's atrial fibrillation is valvular in origin, then you give warfarin. If the patient's atrial fibrillation is non-valvular in origin, then you give direct oral anticoagulant. You see? So what they will be testing is that, do you even know when to give warfarin? Do you know when to give this direct oral anticoagulant, which can be direct thrombin inhibitor or direct activated factor 10 inhibitor? So for this direct activated factor 10 inhibitor, you'll be seeing this XA in their name, apixaban, rivaroxaban, and the likes. For the direct thrombin inhibitor, you'll be seeing something like dabigatran. bifalirudin. Do you get me? Agatroban. So you'll be seeing all those stuffs in the name. All right. So these are the direct Robin inhibitor, activated factor 10 inhibitor. So any of them. But the question they will be asking is, do you even know when to give warfarin or this DOAC? If the atrial fibrillation is valvular in origin, you give warfarin. If it's non-valvular in origin, you give DOAC. That's the answer. All right. So let us now come down to how you are going to treat atrial fibrillation. Let me quickly show you before I release you to go. The first thing you must do in the exam, any exam, whether US, UK, Canada, Australia, Nigeria, Ghana, I don't even care, you check for the hemodynamic stability of that patient. What is the, so when they are giving you, they want to write down your plan, or someone is calling you on phone and the person is asking, Chief, what do I do? Chief, what do I do? You only ask a question. What is the blood pressure of that patient? Is that patient in pain? What about you hope the patient is not in failure? These are the questions you ask. If the question is like, no, blood pressure is okay, the patient is not in pain, is not having chest pain and the likes, the heart is not in failure, your best next step will be beta blocker. You ask, what is the blood pressure? Chief, there is a patient here, blah, 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 blah. What is the blood pressure? Low. You're having chest pain. In fact, that is, the answer was the best next step. The answer is synchronized cardioversion, immediate one. Usually in the exam you are about to write, this is all the test. Just this. So you can just sit down and be like, God, I'm going into the exam hall tomorrow when I get there. So just let them, I thought they were asking about the management of this atrial fibrillation. Let it just be this. Let me just pick the synchronized cardioversion or beta blocker and go. The others, you can ignore them. I'm not saying you should ignore them, but you can just pray that simple prayer and you just get into the exam and the question is just that easy or simple. So you will check, are you stable? If the patient is hemodynamically stable, you don't go for immediate synchronized cardioversion, you go for beta blocker. You go for beta blocker. You go for beta blocker. If the patient is in is having hemodynamic instability, you go for immediate synchronized cardioversion. All right. So that's about that. So let me come back to the rate again. Rate control. The first line drug you must give, beta blocker. Other drugs is non-dihydropirin, calcium channel blockers, and the like. But usually, the question they ask stops at the level of beta blocker. So you don't give yourself headache. What about the rhythm? Rhythm control. Don't forget that atrial fibrillation is abnormal rhythm. You need to control it. So you must ask a question. We know you don't like to ask questions. You ask this doctor that is calling you, how is the patient? Is the patient stable? Blah, blah, blah. He's like, oh, yeah, hemodynamically unstable. You say, go and do synchronized. Maybe I've shown you how to do it. You do that one. Another day, there is another patient with atrial fibrillation. Is this patient stable? The patient is stable. Go for beta blocker. And the doctor is responding that, yeah, I've given the patient the beta blocker. The next thing you want to do is to control the rhythm. Now, how are you going to control the rhythm? Before you do the control, you must ask another question. For how long has this patient been having the atrial fibrillation? If the question says the patient has been having it for more than 48 hours, you must first of all assess for thromboembolic risk. You must assess for thromboembolic risk. Or if at all you don't know, because your assumption is that this patient, if there is stasis of blood in the heart for more than 48 hours, maybe some clots might have been developing. So if you go and cardiofat that patient, there will be dislodgement of those clots or embolus, and the next thing patient will develop is stroke. So you don't even want that. So what you must first of all treat that risk, thromboembolic. So that duration of 48 hours is very important. You must look for it. You must ask about it. If the duration is more than 48 hours, there is a high risk of thromboembolism. So don't forget that you've already controlled the rate. The only thing that is remaining is the rhythm. You will now give the patient 3 weeks anticoagulation. You place the patient on the anticoagulant for 3 weeks before you even say, okay, now let's go and cardiofat the patient. Let's go and do the rhythm. Let's go and correct the rhythm. If the duration is less than 48 hours, you can still go ahead to cardiofat before you even place the patient on anticoagulant. And that is what USMLE wants you to know and bring to the exam. Are you even aware of this 48 hours golden rule? Are you aware? So when they are saying someone has been having atrial fibrillation for 5 days, they are not just interested in updating you about the total number of days. They could have said persistent. They could have said this. They could have said another thing. But they need to give you that duration because they want to test you on this fact. Are you aware that you need to place the patient on anticoagulant for like 3 weeks before you cardiovascular once the duration is more than 48 hours? Or you just cardiovascular straight up if it's less than 48 hours, because the thromboembolic risk is actually very low in those that have been having it for less than 48 hours. So you must remember 48 hours in atrial fibrillation. So when you get to your discussion group, ask your friend, like, with respect to cardiovascular in changing the rhythm, what do you want to quickly check for in the question? And be like, I want to check for that 48 hours golden rule. And be like, check for that duration. Is it more than 48 hours? I want to place the patient on anticoagulant for 3 weeks. Is it less than 48 hours? I can still take my chance. And that's all. Now, the question is that we factor in all these 48 hours or no 48 hours. Now we want to cardiofat this patient. How are we going to do it? You can actually do electrical cardioversion, or you can use drug. You can use electrical cardioversion, you can use drug. All right, you can use pharmacology cardioversion. But USMLE hardly has question around is it electrical or non-electrical. So yeah, they just want to test you on this key point: the duration, 48 hours rule, rate control drug, hemodynamic stability. Then stroke prevention. How are you going to prevent stroke? You now check, is it valvular or no valvular? All right, so that's what they expect you to bring into the exam. These are the pharmacologic drugs you can use to cardiovascular. I call them FADIP, flecainide, amiodarone, dofetilide, ibutilide. I think they love this ibutilide a lot and flecainide in a way. So P, propafenol. It doesn't mean they will ask it, but you see them mentioning it in some questions, like in this question banks, I mean. All right, so that's just by the way. And if you want to use electrical, you can use electrical cardioversion. All right, so what is the last thing? If I thought the atrial fibrillation is still there, you've stabilized the patient is okay, but the thing is still there, and the patient is asking, is there nothing you can do for me? So what you can do is to go and do ablation. Don't forget the last thing, long-term management. You can go and do ablation, and in ablating, you go to those pulmonary vein ostia and ablate that region. So most of those depolarizing cells will be killed. So they won't be able to depolarize again. All right. Okay, so let me just show you 1 or 2 questions that you want to put at the back of your mind and see the way they play out in atrial fibrillation. I know you are not interested, but just for you to have an idea anyway. Just 1 or 2, not many questions. 42-year-old woman comes to the I will just show you how we do the thinking so that you have an idea of how you will be doing the thinking in the exam. So, and there is no right or wrong answer. If you get it right, fine. If you get it wrong, just check again and be like, okay, what did I miss? Is there something I missed here? That's how you look at it. Before you start crucifying yourself that, oh, I don't know. No, you know it. 42-year-old woman comes to the physician because of a 5-day history of intermittent palpitation. She has no history of syncope or chest pain. She had similar symptoms 1 year ago. Following workup has been treated with daily flecainide since then. So she drinks 1 or 2 glasses of wine on the weekend. Some people develop atrial fibrillation from alcohol. So she does not smoke. Her pulse is 71. Blood pressure is good. A complete blood count shows no abnormality. Serum, creatinine, electrolyte, TSH are within normal limits. So all these things you understand. ECG is showing atrial fibrillation. Ablation near which of the following sites would be most appropriate for long-term management for these patients? So that would be what?
Pulmonary vein opening.
Pulmonary vein opening.
Yeah.
Yeah. So this is another one. I want you to look at this and pick your answer. I hope that's all for the options. Ish. Oh, go. All right, so that's fine. So a 21-year-old woman comes to the physician because of a 2-day history of intermittent palpitation. You don't know what is going on. She's a junior in college, and the symptom began when she returned to her dormitory after a 4-hour bus trip from home. The palpitation have worsened since then and occurred more frequent. Sincerely speaking, you don't know what is causing this patient palpitation, but one thing you notice is that if it's going to be AFNRT, they usually occur suddenly and they terminate suddenly, but atrial fibrillation will still linger. It doesn't start suddenly most of the time, then it can linger for a while before it's going to terminate. So you can use that one to have an idea of maybe it's this, maybe it's that. All right, so she does not have any chest pain or shortness of breath. The patient has smoked 5 cigarettes daily for past 3 years. She drinks 4 to 6 alcoholic beverage with friends on weekend and try marijuana once in freshman year. She is sexually active with her boyfriend and takes on an oral contraceptive. She is in no apparent distress. Her pulse is 102 irregular. Respiration at 25. Blood pressure fine. The pupils good. Physical examination shows a fine tremor, both hands and warm extremity. There is 1 plus non-pitting bilateral pretibial edema. Lungs are clear to auscultation. ECG is showing atrial fibrillation. So let me show you the ECG. So see, can you see this area? You cannot really say that this is the P wave. You can't see any identifiable P wave here. Can you see? You can't see. Can you see? Yes. All right. So that's why you say this is atrial fibrillation. Okay. Which of the following is the most appropriate initial step? So what is the answer?
TSH level.
What do you say?
I'm looking at TSH level.
TSH level. So why are you going for TSH level?
Yes, tachycardia and yes,
Tachycardia, fine tremor, and the line. So let us assume that TSH is done. What else will you, what will you have gone for? TSH is done and it's normal.
You want to check the other electrolytes before doing the transthoracic echo.
Yeah, look at this option. Which one will you have gone for? Here. Let's just assume that TSH is normal. And this is
Urine
not
toxicology.
I love that. Obtain urine toxicology because you want to check. This is a young patient. I'm not expecting you to have valvular problem. Do you see the way you are thinking there? I'm not expecting you to have a valvular problem. How come now? Hope you are not on drug. Hope you are not abusing a substance. Your answer will now be like, go and do urine toxicology screening. But you know that could also explain the fine tremor and the warm extremity that the patient is having. But you know, you need to first of all rule out the hyperthyroidism. So, do you understand my explanation?
Yes, sir.
Okay, all right.
Yes.
Or is there anybody that wants me to explain my thought again? Okay, nobody.
Yes.
Oh, yes. Okay.
Yes.
Now, if you look here, you realize that this is more or less like hyperthyroidism. You're already thinking about that from fine tremor, warm extremity, myxedema, and the likes. You're already thinking towards something like, oh, I hope this is not what we am dealing with. So they ask you, what do you want to do? Appropriate initial step. They've already done ECG. Don't forget the orderliness. You will go for your TSH. So let us assume that you check for TSH here is not there. Or the question says they have done the TSH is normal. What's the best next step you want to do? You will now be thinking, I hope this is not a substance abuse. Because this is a young patient. I can't even be thinking towards valvular problem. I can't be, because the patient is not of age to be having valvular problem. Where will that one be coming from? Do you see the way you are thinking? Be like, hope this is not a substance abuse. So someone like me will first of all even go for option E and be like, most likely is substance abuse. Go and do the urine toxicology for this patient. So possibly you can pick 1 or 2 things from the urine, because this is a young patient that can abuse anything at this age. So that's how you do the thinking in the clinical world. So that when you are saying that maybe during ward run, you are saying that go and do TSH and the next thing is TSH is normal, electrolyte is normal, that one is normal. You should be able to say, go and bring the urine of that guy. They bring the urine, you just see all manner of substance there. And that could be the cause of the atrial fibrillation. So, okay, let's do this. I want you to answer this question. And you explain why you are choosing your answer. 40-year-old woman comes to the mind department due to 6-hour history of palpitation. She described fluttering in the chest that has never happened before. In addition, over the last few months, the patient has experienced anxiety, fatigue, 7 kg weight loss, medical history is unremarkable, and she takes no medication. The patient does not use tobacco, alcohol, illicit drug. Blood pressure is looking okay, pulse is high. Examination revealed lead lag, fine tremor in their stretched hands, no murmur are audible, lungs are clear, ECG shows atrial fibrillation with rapid ventricular response. Which of the following is the best next step in the management? So what is the answer? This is all about drug. Which drug do you want to give? Treatment. What's the
Beta
answer?
blocker, propranolol.
You see the way you...
Propranolol.
So what do you look for before you go for your propranolol?
If the BP was fine.
Is this patient hemodynamically stable? So if you check this patient is hemodynamically stable. So you can go straight to your rate control, beta blocker. So which drug is ibutylide?
It's for
Pharmacologic.
cardiovascular.
Yeah. What of flecainide? Pharmacologic
The same
cardiovascular.
Also
For
for
exactly amiodarone. So before you are going to give any of these drugs, what are you going to check for?
how long
Duration
the
of
patient
the
has had
AFib.
duration. So that
Exactly.
is
We want to check for the duration. So if the duration is more than 48 hours, what are you going to do? You place the patient on what?
Anticoagulant
Anticoagulant for
for
3
3
weeks.
weeks.
For how many years?
3
3
weeks.
weeks.
3 weeks. So that's how you'll be looking at this thing. So I think for now, I have been able to confuse you and not convince you that that this is not a bad idea. So let me just quickly differentiate this for you so you know that you are done completely here. So synchronized, we've been shouting synchronized cardiovascular, synchronized cardiovascular. We also have unsynchronized cardiovascular. That unsynchronized one is what we call defibrillation. Do you get it? All right. So, and you know when, under which condition you use this defibrillation, you know what to check for before you know is defibrillation I'm going to use here. You know what you are going to see before you know that is synchronized cardiovascular I'm going to use here. All right. So don't forget all those stuffs. So synchronized cardiovascular purpose low energy shock, which is timed with the heart wave. Do you get it? However, with respect to defibrillation, you are not timing anything. The only thing you shout is clear, clear. Clear, clear, clear. So it's an object indicated for non-perfusing reading or when synchronization fails. Do you get it? So that's what you look out for. So you synchronize this one with T wave. That's why you see they call it synchronized cardiovascular. It is during T wave you release the shock. Do you get it? Sorry, you give it during hard wave. That's what I wanted to say. Sorry, you give it during hard wave. Low shock, time with the hard wave of the KRS complex. All right, whereas for this one, you are not timing it for anything. And this one is low energy. This one is high energy shock. Defibrillation is high energy. Synchronized cardiovascular is low energy. I usually give this when the patient is unstable. So don't forget. If you go and give it during T wave, that may be very disastrous and that may even kill the patient. So you need to be very careful. So you give it during hard wave. So correct my error. All right. You see this pulseless electrical activity and ACE2, they are not shockable. You don't shock them. So when you do your CPR, the next thing you do is give is happy. Don't go and say I want to give, because they already have what do you call it? They have an activity already. Don't go once you do your CPR, just give your happy. And with respect to all these ventricular fibrillation and the likes, don't forget the way you DD, what? That day. Don't forget that mnemonic. DD, that day. So you just write it down, say it one time or twice, and you okay with that. All right. So the next time I have the opportunity to sit down with us, I'll be taking us through heart failure. I know you know heart failure, but I would love to show you how you look at heart failure in the exam. Have you been able to learn one or two things today, if I may ask?
Very much, sir.
All right. Thank you
A
so
lot.
much. Thank you so much for
Thank you, Professor.
learning something from us. All
Thank
right.
you.
Okay. So, for those that want to go through the entire material, you can get across to the secretary so that if at all you are interested, they'll be able to get it, use it, and in a way, quickly. Don't let this policy, what do you call it, slow down your preparation. I said it before we started. In fact, you can quickly use this period to like quickly fine tune your preparation, write your exam, so that by the time everything will be over, you're already ready. But if you say is when everything is over, you are going to start, I think that's a very big deception. So that will not really help you. And most of what you are even reading, you will have forgotten. So don't let it slow you down. Just continue with your preparation. I wish all of us Merry Christmas in advance and Happy New Year in advance.
Thank you,
And God
sir.
will crown all our efforts in life. Don't be discouraged in any way. Just be encouraged. That's how the journey has been. And that's the little headache we have in it. So I think someone wanted to ask a question. If I thought you have, does anybody have any question? All right, no question. Thank you so much. If I thought you have any question, you can easily get across to us. Enjoy the rest of the day. Bye.
Thank you, sir.
Thank you,
Thank
sir.
you.